thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm really honored to welcome you to this week's webinar titled Fertility Education for Adolescents and Young Adults with Cancer. And before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. So if you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. And before I introduce our speaker today, note that your video and microphone are automatically disabled for this webinar, but we really encourage you to enter your questions into the Q&A feature found at the bottom of your Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all of the questions today, but we'll get to as many as possible. So I'll go ahead and introduce our speaker. Estella Barrios is a licensed clinical social worker with credentials in both oncology and palliative care. She is the Adolescent and Young Adult Program Specialist at City of Hope Comprehensive Cancer Center. Her oncology expertise is in lymphoma, stem cell transplantation, and graft versus host disease. She practices actively in the sarcoma and lymphoma outpatient clinics alongside the multidisciplinary team. And in her 11-year career at City of Hope, she's provided therapeutic interventions as well as grants and resources for patients throughout their treatment trajectory. In her current role as program specialist, Estella aims for the best possible psychosocial outcomes for the adolescent and young adult patients and survivors that she sees. And it really gives me the greatest pleasure to welcome today's speaker, Estella Barrios. Estella, thank you for joining us today.
Thank you so much for that warm welcome, Kathy. And hello, everyone. I'm so happy to be here with you today. I'm going to jump right into the slides, and we're going to be discussing fertility and cancer. My presentation is going to be about 40 minutes with plenty of space and time at the end for questions and answers, which I absolutely want to hear from you guys on. The plan for what we will be discussing is first and foremost, why fertility matters, why providing goal concordant care in the cancer setting is so important. We're going to go over the impact of cancer treatment on fertility. We will be discussing fertility preservation options. There are many. We're going to go over starting the conversation with your provider. How do you do that in the cancer setting, in the exam room, in family meetings with your medical team? We're going to discuss access to fertility treatment, fertility resources, and as I mentioned, Q&A at the end. Please write your questions down as I go through the slides. I will be answering them at the end. And jumping right into it is, why should we discuss fertility? Why is this topic so important? And it's important because the overall survival rate for AYAs, adolescents and young adults with cancer, exceeds 80%. So we have a high amount of survivors that are in this bracket and have shared that their quality of life really is impacted. Their quality of life takes a hit when it comes to their reproductive health and the ability to, for those who desire it, to have a biological family, to conceive a baby. And we did learn, the data suggests and research has shown that patients that were given the option and that were given counseling on fertility and sexual health at the time of diagnosis, those patients have reported higher levels of satisfaction with their fertility decision, and it improved their overall coping compared to the patients who didn't have that conversation, to the patients who were kind of just rushed straight into treatment and never had the chance to go over fertility and what it meant to them. And finally, it's important because we do want to discuss fertility goals of adolescents, young adults, and spread awareness on the importance, spread awareness on having ample knowledge and resources, referrals, counseling at the oncology setting in the setting of your comprehensive care. And so what does it mean to provide goal concordant care? This is something that I had mentioned in a previous slide, but what does that mean? It is that you as a patient make that decision for yourself. So rather than the provider, rather than your team making the decision for you, you're able to say, yes, I would like to have a baby in my future, and so I want to move forward with preservation. Or receiving the education and deciding, you know, a baby is not something that I had planned for, let's proceed with treatment. And really just being able to define your individual fertility goals. So you making that decision rather than someone else making the decision for you, that is goal concordant care. And that is what we're striving for as providers in the multidisciplinary setting. So the key is just having the conversation. Whether you fully move forward with preserving and sperm banking or preserving oocytes or not, the key is just to have that talk with your doctor. We will go over in a later slide really how to get that conversation started, because it could be a bit of a challenge. There are a lot of components that come into play when discussing fertility care. A lot of things matter, like what your values are, your sexuality, your psychosocial situation. So do you have family support? Do you have friend support? Your financial resources, it could be very costly. If you have a partner, and what your gynecological or urological health is. All of these factors come into play when we're discussing fertility care. And the impact of cancer treatment on fertility could be extensive. The cancer itself can affect your fertility in terms of your reproductive system. So is the cancer in your testicles and your ovaries? The treatment for cancer can affect your fertility. So is it radiation? Is it chemo? Is it surgery? And then treatment may also affect your sexual functioning and body image. So if you have scars on your body, you're feeling less sexy, less interested in engaging in, romantic activities and intercourse with your partner, or sexual functioning. You're done with treatment and you're still fertile, but you're experiencing erectile dysfunction or vaginal dryness. And those are all side effects of cancer treatment. There are a lot of individual factors to consider as well, like the age and cancer type, your fertility status before treatment. So did you have a condition like PCOS? Your desire to have a baby, of course, is very important. And then other individual factors are the type of treatment that you got. So if it was chemo, what was the type of chemo? What was the duration? What dose did you get? If it was radiation, where was that radiation and what was the dosage? If you got surgery, where was your surgery and what type? And then immunotherapy, so targeted immunotherapy, what type, what duration, what dosage, all of these things come into play when we're considering fertility. And we highlight this as very individual because there have been instances of adolescents and young adults assuming that they're infertile automatically based off of, a sister's neighbor who had cancer and is no longer fertile. That person's story and outcome is going to be different than your story and your outcome. So it's very important to discuss with your provider what type of treatment you're going to get and the risk that it has on your fertility. Going into a little more specific on females and what you might expect. There could be fertility at the end of your treatment, still having the ability to conceive, but going into early menopause. There's also intermediate menopause and then general damage to the reproductive system, which can take place, and a lack of estrogen. We have found in the data that about 70% of women who had high-risk treatment do develop amenorrhea, which means the absence of your menstrual cycle, while 30 to 70% of women that are treated with intermediate risk can develop the absence of a menstrual cycle. All that is to say, though, that the presence or absence of a menstrual cycle doesn't necessarily automatically mean fertility or infertility. A specialist is always going to be highly recommended. The fertility preservation options for females, there are many. As I had previously mentioned before, there's embryo or egg banking. This does take about 10 to 15 days, and it ideally is done before or soon after treatment ends. There's also ovarian tissue banking, which is still experimental, but specialists are still recommending it for various reasons of success rates. There's ovarian transposition, radiation shielding, and ovarian suppression. These are all very well-known preservation options that women can take. And then testing for females after treatment, or even at the time of diagnosis, can be done. So treatment itself can induce early menopause. So even if women are still menstruated after treatment, it's uncertain how long she will be. And so this is a list of the labs that can be done for women. FSH, estradiol, and AMH are well known to give a general layout of how a woman's reproductive system is working and whether it's healthy. There are also ultrasounds that can be done. And finally, if applicable, it's highly suggested that women undergo a health exam to understand the health of your uterus, your cervix, your fallopian tubes. For women, it's a bit different because there's fertility on its own, and then there's also your health and ability to carry a baby full term. And so understanding whether that's possible is highly important, and we recommend speaking to a reproductive specialist to have that conversation. And other things to note for women is that not all cancers and cancer treatments will affect your ability to have a baby. Some treatments for lymphoma per se are very low risk, less than 10% risk of infertility. And another thing to note is that even if your periods return, damage to your ovaries from your cancer treatment may put you at early menopause. So there could be fertility that's still in place after treatment, but you might expect to go into menopause 10 or even 20 years earlier than you would have gone into menopause had you never had cancer. And so it kind of speeds up your timeline of when you want to start expanding your family. And so these are things to take into consideration. Eggs, embryos, and ovarian tissue can be frozen for many, many years. So patients that are in their late teens, early 20s that want to preserve, it's helpful to know that they can be stored for you for years to come. And talking to your team about, once you're done with treatment, when you would like to start trying to conceive. Some doctors will recommend 6 months after treatment. Some will say to wait 5 years. Again, this is because of your fertility status, but also your ability to carry a baby and safely for you and for the baby to full term for 40 weeks. And then your return, again, the return of your period doesn't always mean that you're fertile, or the absence of a period doesn't always mean that you're infertile. Just understanding that some people have irregular cycles, and so talking to a specialist about it. And finally, I'm going to say this a couple times throughout the presentation, but if you're not ready to become a parent, it is important to use contraception regardless, even if you think you're infertile. We do always want to be mindful of sexually transmitted infections or diseases, and so staying safe. Another thing we want to underscore here is that children that are born to cancer survivors, they are not at high risk for birth defects or cancer unless the cancer itself is known to cause a genetic mutation. And that is something that we can test for as well via genetic testing. Special considerations to take for men is early, delayed, or absent puberty for boys. Infertility due to low sperm count and a lack of testosterone. Men who have had high risk treatments, and if you're not sure the risk of your treatment, this would be something that you discuss with your doctor. High risk treatments can cause permanent or prolonged azoospermia. So this is the absence of sperm in your semen. Low risk treatments can recover over time. Your sperm can recover over time if your treatment was low risk. It can take months or years. And these things can be assessed through semen analysis, which I will visit in a later slide as well. Fertility preservation options for men, there are many. The process for men to preserve is a little easier, simpler than for females. For men, it's sperm banking. There are various sperm banks in the area, in the Los Angeles area, and essentially what men would do is provide a sample in a sterile cup to a sperm bank. And again, it can be stored there for years and years until you're ready to access the sperm. There's also testicular tissue freezing. This is for prepubescent boys. And then there is radiation shielding of the testes. So this is to protect while a man is going through radiation treatment. These are all forms of preservation for men. And fertility testing for males is, there are several options as well. There's semen analysis, there's sperm function tests, hormone tests, urine analysis, and genetic tests. These are all things that can be ordered or discussed or taken care of by your medical team. You also can do this separately through a fertility center. Some things that are important to remember for men. Not all cancer and cancer treatments will affect your ability to have a baby. Sometimes there is minimal risk. Sperm banking is the most successful and least expensive way to preserve your fertility. And if you're going to conceive, it is recommended usually for men to wait from 6 to 12 months after chemo and radiation. Again, it's important to discuss it with your doctor, but generally giving it a few months, even a year, is what's recommended. Sperm production can return immediately after treatment, or it could take a while for the sperm to recover. And again, if you do not want to become a parent, then it is highly recommended to use contraceptives. Even if you think you're infertile, we do come across this with young adults very often, assuming blanket automatic infertility and therefore not having protected sex. And so we do discourage that. Just stay safe. And again, children that are born to cancer survivors are not necessarily at higher risk for birth defects unless the cancer itself has involved a genetic mutation. And you could absolutely discuss genetic testing with your medical team. And so in previous slides, I did talk a lot about talking to your medical team, talking to specialists, but how do you do that? It can be a little challenging. The medical setting, the exam room, the consults that you have with your providers are stressful environments at times. The doctor has a plan usually and is really moving quickly to get you through treatment, where as a patient, it's hard to ask the doctor to pause, especially if the doctor doesn't bring it up first. And so how do you wedge yourself into the sentence and say, hey, this is something that's important to me. This is something that I want to talk about. I do want to give tips on letting you know that it's okay to address the topic before the provider does. Sometimes the doctor is just focused on getting you well, getting you cured, getting you to treatment, and might not necessarily bring up fertility. And it's okay for you to approach it first. The doctor might not have all the answers in the moment, but they tend to refer you to the correct person. Doctors do not work alone. There is an entire team behind them. So whether it's a social worker, a nurse, or someone else they might have a fertility specialist at their facility, we encourage you to ask and bring up the conversation, especially if it's something that is very, very important to you. It's also okay to do your own research. And so you could bring it up with your oncologist, but also understanding that there are fertility banks and fertility treatment centers in your community that you could absolutely pick up the phone and call. We do recommend letting them know that you have a cancer diagnosis, because it does set you aside from other people that are electively seeking preservation efforts. And then just some scripted questions that you can take away to ask your doctor is, how will cancer and cancer treatment affect my fertility? Or can you refer me to a fertility preservation specialist to discuss my options further? These are somewhat, these could be difficult to remember when you're in the exam room. A quick and easy way to bring up the conversation is to just simply tell your doctor, I want to have a baby later on. Is that something I can do? Is that something that you can help me with or get me information on? You can also let the doctor know, I'm not sure if I want to have a baby later, but I still want the option. And can you please refer me to the appropriate person? And some psychosocial considerations to consider are whether you're partnered or unpartnered and how to have that conversation, how to discuss children in your future. So there have been instances where at diagnosis, the young adult is newly married, maybe 6 months, 8 months into their marriage, and they've been diagnosed, and now they're being asked about fertility. And how do you even have that conversation? We do want to acknowledge that it is difficult, it can be challenging. And oftentimes a fertility specialist at your center can help you with that, or even a social worker. And the conversation of family planning in general can be emotional, and it's okay to process those emotions with your care team, fertility specialist, or social worker. As I'm discussing, scripts to bring up with your team, or just the logistics of getting to the preservation phase and making those appointments and getting treatment for fertility. I do understand, and your treatment team often will understand that it is a very emotional process. And so it's okay to cry. It's okay to tearfully ask for some more information or resources because it's important to you. It is important to us and is important to your care team. Another psychosocial consideration is that it can be costly. It is sometimes covered by insurance, and we'll get into that a bit later, but finances can play a very large role in fertility preservation and could often impact one's decision to proceed. And it's okay to ask the person in front of you, whether it's the doctor or your social worker, asking them, is there financial assistance for me? Is there another insurance that I could apply for during open enrollment that might cover me for this preservation? It's okay to kind of challenge the provider in front of you to ask, what financial aid might you be able to find me so that I could proceed with preservation that I can't otherwise afford? Access to fertility treatment is a little more attainable with this new legislation that came into play in 2017, where various states are now able to provide fertility preservation coverage, which is covered under insurance. So in California specifically, California has SB 600, which highlights that if your infertility is directly related to a cancer diagnosis or pending treatment, then your insurance carrier is required to offer you preservation coverage. There are some caveats. It's not as perfect as we wish it were. Your insurance does have to be commercial, and it does have to be in California, but it is a start, and I think we are trending in the right direction, and it has provided access to many patients who didn't have access before. We do still have a ways to go, but I do encourage you to screenshot this or know that if you have commercial insurance that is based out of California, that you likely have preservation coverage. The word you would use is iatrogenic infertility. That is kind of the buzzword that you would let the insurance carrier know. And so paying for treatment for fertility, as mentioned, it is rather expensive. Egg freezing for women can range anywhere from $10,000 to $15,000. Embryo freezing is a bit more costly at $11,000 to $15,000. And then banking for men is on the lower end, $500 to $1,000, but there are constant changes in price for men. And we have come across sperm banks that have offered as low as $350. Again, I do encourage you as patients, when you're calling to make your appointment, or if your fertility specialist is making the appointment for you, asking about discounts for cancer patients. One thing to note is that when you're going to a fertility clinic, you are in the oncology bracket, but other patients there in the waiting room at a fertility office might be there for elective reasons. And so you always want to bring up that you have a diagnosis of cancer, that things are a bit more time sensitive for you because treatment's going to be starting soon. And do they offer any discounts? Do they have any type of assistance for you given that you have a diagnosis? And can they see you sooner? You might not be able to wait 2 weeks before you see a fertility specialist. Really asking, can they expedite your appointment because your chemo will be starting soon? This is something that we encourage for both males and females, kind of setting yourself apart from the people that are there for elective reasons. And these are some of the prices for our pediatric patients that are undergoing ovarian tissue cryopreservation. And then there are some post-treatment options. If you didn't have the opportunity to bank before treatment, which sometimes happens, a lot of the time the provider is focused on preserving your life, taking care of you, making sure that we get you into the stage of survivorship. And so fertility preservation might have been an afterthought, but circling back to it and understanding how to access donor eggs, donor sperm, and donor embryos so that you can still have a family later on. And then fertility resources is, again, here, if you'd like to screenshot, these are all organizations that will offer fertility, either financial aid, education on fertility, clinics in the area that you could visit that will offer services, or grants to just outright cover the cost of your preservation efforts. Many times, if you go to a fertility clinic on your own, they might already be connected to organizations like Livestrong, and so they might do some of that legwork for you. But it's helpful to know that there's options out there to cover some of the cost and answer some of your questions as well. And that brings me to the end of my slides. I thank you all so very much, and I'm happy to answer any questions. Kathy Riley is back on with me. Thank you, Kathy. And Kathy's going to help me kind of field some of the questions, and I can't wait.
Great. Thank you so much for that meaningful presentation. I learned so much. So thank you for sharing with us and giving us this space for discussion as well. We invite everyone to type your questions into that Q&A feature. We've already received some great questions, so I'll start with some of those. And you mentioned Senate Bill 600 in California. Someone is asking, do you know if egg storage is covered under SB 600? And if not, what are some ways we can lessen the price or have that covered?
So ongoing egg storage beyond the initial preservation, SB 600 does not cover the follow-up years of storage. Let's say if you reach year 3, 4, 5 and need to have it paid for. There are organizations though outside of SB 600 that can cover. So financial aid via the SAM fund is specific to survivors, and they will help. They have a grant that will cover storage.
That's great information for us to have. And then a follow-up question to that from the same participant. How does surrogacy work? And are there ways to get those expenses covered as well for cancer patients and survivors?
Oh, great question. So surrogacy, that's a very long, I would have a long-winded answer. I would say for that question, specifically speaking with the specialist, the family planning specialist, or getting connected to one. So if you have a clinic in mind or someone that you're working with while in survivorship, they could give you the information on how to obtain a surrogate. There is grant funding available usually in the community. But it's I would say to speak to the specialist about it.
That's great information. Thank you. Another question, and there's actually two questions that belong together. The first is, how are we able to tell or know if we are approaching early menopause? And then the second part of that is this a question that we should be asking a gynecologist or an oncologist or hematologist?
Great question. One thing to note is your menstrual cycle and the pattern that it was before cancer, and then if it returns to that pattern after treatment is over, and what the cycle is like. Is it regular? Is it irregular? Does it start on the same day, or do you occasionally skip months where you have no period and then it begins again? Because there's also intermediate menopause where it seems to come and go. But overall, the absence of period and sometimes the symptoms that come with menopause could be an indicator, like hot flashes. And there are tests to the tests that I highlighted in one of the slides, which were FSH, AMH, and estradiol. Those are, it's simple labs that you can do at your treatment center. And those lab results will indicate whether you're menopausal, premenopausal. And you can take those results to a fertility specialist to begin the conversation of, what happens next.
That's great. Thank you. And then another question we've received, someone is asking for guidance to see a fertility specialist to check in on your fertility status when you're not trying to have kids. They've had trouble getting prioritized because they don't want to have children, and actually received some instruction from a team to lie to be seen, but that doesn't feel great. And so any advice or guidance on how to handle that situation, because the individual is saying I should be able to understand what's happening in my own body regardless of the reasons behind it.
Yeah, the answer would be different whether is it a male or female that's seeking the information. Is the patient?
Sounds like it's a female patient.
So for female, there are specific fertility practices that are in the oncology. It's oncofertility. So patients that go to see those specialists are only those that are in the cancer setting. And we usually rely on those providers that will sort of expedite or see oncology patients sooner or in a timely manner versus the general elective fertility clinics who kind of see the larger people in the community that just have general infertility issues. So there are, depending on where this person lives, there are some in Orange County, there's one in Santa Monica, there's one in Pasadena, but Google searching onco fertility clinic in my area and it'll populate some information. And then having the conversation over the phone when making the appointment that they're an oncology patient, they're not actively pursuing conception, trying to have a baby right away, but want to know what their reproductive health is after treatment. And then when they do show up to that appointment, having their medical records with them or available, sometimes having your doctor's office send your medical records or most recent history and physical, sending that over to the fertility clinic, because that's what the fertility specialist is going to base the conversation on and be able to give you more accurate information.
That's great information. Thank you. And then a great question about navigation. So outside of a nurse or doctor or social worker, is there anyone else that could guide a patient through fertility navigation?
Great question. I wish there were more navigators. It's somewhat of a gap that is slowly being addressed. There are more and more navigators that are surfacing in the community. But I would say the best first start is going to be a social worker, sometimes a nurse, a registered nurse in your medical setting, someone on your treatment team. The best response is usually to not suffer in silence, to bring it up to your provider and say, this is something that's important to me, and I need a little extra help making those appointments. There's a lot of legwork that's involved. And so is there someone on your team that can help me figure this out? And typically the doctor or the person in the exam room with you is going to know more about the internal resources and could put you in the hands of the right person. versus you as a patient trying to figure out who works there and who to talk to. I would say to bring it up to the team and they can help you decipher.
Thank you. And then a question about options or resources. Someone whose husband died earlier from cancer, but planning on continuing to try with his sperm that was collected before the start of chemo. So, are the resources and the options that you've talked about available to someone in that particular situation?
Yes, actually, it does depend on whether and I'm so sorry to hear of his loss, but if he filled out paperwork that indicated and gave you permission to do that, then you absolutely can. It sounds like maybe he did. When filling out registration paperwork for a sperm bank, it does explicitly ask if in my passing, who is able to make decisions over my sperm sample. Does the bank discard it, or does it get donated? Is it considered an abandoned sample? So understanding what he put on that paperwork first, and then contacting the bank and letting them know the current situation and having them guide you. The sperm banks are very comprehensive. They do maintain a file of the date, and there's an STD panel that's attached to each sample as well, which is required by federal law. So that would follow the sample. And then going to, they typically are partnered with a fertility or like a family planning agency. And so starting the conversation with the sperm bank and letting them guide you. If not, you can also just withdraw, almost like a Bank of America. You could withdraw your deposit from that bank and have it transferred to another bank that has more resources, or take it to a family planning facility that's able to continue storing it and then has the options for the next steps.
Great, thank you. Can you provide any additional resources for artificial insemination? This particular individual has sperm preserved in a cryobank, but her husband is currently going through chemo treatment. However, would still like to look at conceiving. Her health is good, but and I think you mentioned this in your talk, it's not recommended to conceive naturally at this time. So any recommendations for insemination?
Yes. Typically, if as a couple, you've decided that this is the next step for you, this is what works best for you and your relationship, then discussing it with whoever your gynecologist is, someone that you would begin prenatal care with, so your medical team, and then it would happen within network of your insurance. So first understanding what is covered by your insurance as the female, the person that's going to be receiving. And then your husband would kind of, he would proceed with his treatment and almost take a back seat while you understand what your insurance is able to take care of, and the fertility clinics that are available to you. So they will walk you through the steps of accessing the sperm and then implanting, but you would do that with a fertility specialist.
Great, thank you. And then this next question is switching gears a little bit and going to the financial side of things. It's a great question. How have you creatively helped patients financially when there is no funding specifically for fertility preservation?
Great question. I could be here all day talking about it. So it's twofold. A lot of hospitals are like bound by policies and what we're able to extend to patients and what the boundaries are. And so we are working on a few things in my organization at City of Hope to be able to offer at least a portion of financial aid for patients. Beyond that, the organization that you're at, wherever this person is getting treatment, they do tend to have financial aid options available. It might be minimal, I've not come across one that can cover the full $12,000, but at least covering a consult with a reproductive endocrinologist. There is, it's fivefold of what happens when you're with a fertility specialist. Sometimes the oncologist that is giving you cancer treatment, they might not know per se what the risk is to your fertility and how, how risky this treatment will be, but they will give you a referral to a fertility specialist. And that referral might only cost $100, $90. I've seen it as low as $89 to sit in front of a fertility specialist, to give them your medical records, to say, I'm taking this medication, rituximab, and I'm going to take it for X amount of time. My oncologist wasn't sure of the risk of infertility. Can you tell me what the risk is? And that fertility specialist will usually ask for a few labs, but then be able to give you more comprehensive information on what your risk factors are and whether you even need to preserve or not. In some instances, I've been in the room where the patient is able to proceed and doesn't really need to preserve, and they'll be fine just with that risk assessment consult. And in the instances where they do require preservation, then accessing financial aid either through that clinic with agencies like Livestrong, understanding what the insurance coverage is, and then small organizations. There are financial aid agencies like Chick Mission that offer basically a small grant. Some of them are $2,500, some of them are $500. What I've noticed is that you can compile many of them. So if you have time, if the doctor says you have 3 months before I really want to start giving you systemic treatment, and let's say the fertility specialist has given you notice that there is risk for infertility, I recommend preservation. That means you would have those 3 months to fill out financial aid applications, working with your social worker or your fertility navigator, sending those applications in. And I've had a few patients who had them approved. She combined 5 grants to cover her preservation and had to pay just a fraction out of pocket, but it was otherwise covered by various grants. It does take quite a bit of legwork, but with a navigator in place and just with some organization of having those applications and kind of filling them out one by one and sending them in, it is worth it. And I'm very thankful for those agencies that are out there. A lot of their information is on the internet, usually quickly searching oncology, fertility, preservation, financial aid, and they'll populate.
I'm also grateful for those organizations because it's, it's an area where individuals really need that kind of assistance. So thank you for all your guidance, how to pursue those resources. There's an additional comment and then a question that I think there's part of it that I can answer on behalf of CSCLA, and then I'll throw it over to you. Someone is saying what a great comprehensive fertility preservation education presentation this is for AYAs, and excellent content and presentation. And this is a necessary resource at diagnosis. And the question is, do you have any plans to make any of this content available to those who are diagnosed from the cancer support community side of things? And Estella, we talked about this in our little rehearsal we had before the webinar, that we will definitely make this recording available in our video library. So that will be available for those who are newly diagnosed. And if anyone would like the slides from this presentation, you can email us at info@cancersupportla.org, and we'll see that you get a PDF of these slides. So I'll pass it over to you. Any plans to make any of this content available in any form to those newly diagnosed in other ways?
Yes, we do absolutely have plans with our adolescent young adult program at City of Hope, slowly expanding over time and understanding what the needs of our patients are. We do have plans for education and information to be put on our website. We also have our Instagram, where we will promote like education and classes and even support groups. We've had at our AYA support group series, the conversation of fertility and education, Q&A in those seminars as well. And then finally, myself as the navigator, meeting individually with patients when they're newly diagnosed. So we do have a workflow. It's more of an internal process for established City of Hope patients. But part of my role is to meet with patients when they're first diagnosed, and me being the first person to ask them about fertility preservation. Or a doctor has brought it up, but then hand it off to me to finish the conversation and make that preservation appointment. And so our goal is, as I had mentioned, to provide goal concordant care to our patients, making sure they could make that decision themselves. If they decide not to proceed, then understanding that that is still, it's still goal concordant care, and we've done our due diligence in that aspect. Or if a woman, for whatever reason, is unfortunately unable to fully move forward with preservation, then offering counseling and having that conversation with her in the moment, and then being available for later on if she has questions about alternative ways to start a family.
Wonderful, thank you. And then I think I'll close with this question, and this came in from registration. I know we have some providers with us today during this webinar. So from the provider perspective, what is the most appropriate way and the best time to broach the topic of fertility with AYA patients?
Great question. Typically at time of diagnosis, typically when a patient is diagnosed, you're going to start to discuss or decipher what the treatment plan is. And for the most part, a provider is moving as quickly as possible. And so the faster that that treatment plan is going to be activated, the less time we will have to preserve. And so sooner is always better. And we've come across some instances where providers know that it costs a lot of money. Providers know that it does take some time. And so it's very normal to want to shy away from offering fertility when you know that there might not be time on the back end. But really bringing it up to the patient, even if there's no time, letting the patient know that. Unfortunately, I've come across patients in the survivorship space that have said they had no idea that they were going to be infertile, or that the conversation was never addressed. And it's so much more painful and so much more difficult to cope with when they're in survivorship, ready to celebrate, but something that was so important to them is no longer an option. And so it kind of removes from the space of being able to celebrate, because their quality of life is now drastically impacted. So at least having the conversation if there is no time. But I would say at the time of diagnosis is what's recommended. And then knowing the resources in your area, whether it's your own social worker or your AYA program specialist or fertility specialist, bringing it up, and then it's okay to hand off to that person to finish the conversation. It can be lengthy. And so if you don't quite have the tools, or if family's in the room and you feel like it's not the best time to start talking about collecting a sperm sample, just letting the patient know, we're going to talk about fertility. I do have a colleague on my team who's going to call you. Is that okay? And much of the time, patients have always said yes. I've come across patients in the AYA age range who do want to talk. That talking about fertility is different than wanting to fully preserve, but handing off to someone on your team who can kind of finish the conversation and do right by their patient.
Yeah, and I think just as a quick follow up to that, for younger patients then who may have family or parents present, how do you, any advice on navigating that conversation?
Yeah, of course. Typically, when I do meet with patients, if they're not alone, in general, we try to avoid a cold call or a cold conversation because it can be a very emotional conversation. It could also be very awkward for them. We're using words like ejaculation and masturbate. And sometimes patients are just so caught off guard, they can't really even articulate the next steps because you just came in and said the word ejaculate. And so I try to give them a bit of a heads up, calling them ahead of time, giving them a little bit of control over the situation in a series of their life where they don't have any control. The beauty of this is being able to say, I'm calling you to discuss fertility. It's family planning, it's your future, and I'm happy to carve out time. What does your schedule look like? It is a little time sensitive. So is there a time today where you could be alone? Or do you have a partner that you want to be in that conversation as well? I'm happy to come in and let's just dive into it, and I will navigate you through the steps. And then letting the patient answer. There are instances where the patient says, yeah, come in, you know, my mom's here, it's totally fine. Or can you come tomorrow? I will be alone and we can really have the discussion in private. So in the instances where you could give some control back to the patient, I would say to give them that control, especially if you have the time that allows it, and then letting them know what you're going to be talking about. Sometimes even the word fertility is hard to grasp. If you're not in the medical setting, you don't know what that means. So talking about family planning or having a baby later on, and if that's something that you want, I'm going to come in and talk to you about it. When is a good time? I'm on your schedule. And then really just coming in when they say that they're ready.
Great. Well, we have reached the end of our time together. And Estella, thank you so much for generously sharing your time and your expertise with all of us today. And I want to thank everyone who attended for your engagement with us today and for your excellent questions. This will be a great resource for everyone. So thank you to all. And then we have a final slide that we're going to share from the CSCLA side of things. And I will say that I know we were not able to get to everyone's question today. So if you have a pressing question that we weren't able to answer, feel free to email us, and you'll see the email on the screen, info@cancersupportla.org. Please email us there if you have a question we were not able to get to, and we will send that Estella's way. Also, if you would like to learn more about Cancer Support Community Los Angeles, you can visit our website, which is here. And then I'd like to make you aware of two support groups that we do have for young adults. We have a young adult survivor of pediatric cancer support group. If you're interested in finding out more about that, you can scan the QR code there. And we also have a young adults support group, and these are ongoing. And we welcome young adults to attend. And with that, I will say thank you to everyone, and we will see you at the next educational webinar. Have a great day.